Can you show the screen with just the one slide? There you go. Okay, so I'm Dr. Elena Rios. I'm President and CEO of the National Hispanic Medical Association, and we're very happy today to have our event with 2 chapters in the Midwest coming together for the first time, or for a long time actually, on virtually. And I just want to say just a couple things. I want to encourage everybody right now to enroll and to inform others to enroll in the clinical trials that are being done in the country for the COVID-19 vaccine that we hope to have, by the end of the year or early in the next year. And there are 2 major websites. NHMA is helping with enrolling and encouraging others to enroll. The first website is coronaviruspreventionnetwork.org, and that is the Moderna clinical trial that is being done through the NIH system. And we have the COVID vaccine study1.com, which is the Pfizer clinical trial. And they have sites all over the country to be able to make it easy for doctors and nurses and others to tell their patients to please enroll. The reason why we think it's important is because we need more diversity within the knowledge base of the research for vaccines. And we also need to know how these vaccines impact different people. And, Latinos and African Americans have always been at the very limited numbers of participants as well as investigators. And I also want to let you know that we have continuing medical education for this event, our webinar tonight. And in the thank you email, there will be a link to the CME. And also this event is being recorded, and we will be providing CME for a year at our website, which is nhmamd.org/webinars. And lastly, I just want to thank our sponsors tonight. We have actually 2 sponsors tonight, the Pfizer Inc., as well as the Blue Cross Blue Shield of Illinois, which is, and we're very interested in working with Blue Cross Blue Shield. I have to say that we talked earlier this year, Derek, with your predecessor, on the importance of having tours and getting students and doctors to understand the importance of working within our healthcare industry, in this case, an insurance company that's right there in Chicago. And we hope to that Pilar and Javier can follow up with making those tours happen. So I want to turn it over to our moderators, Dr. Pilar Guerrero, chairwoman of our Chicago chapter, and Dr. Javier Sevilla Martir, who is the chair of our Indianapolis chapter. So Pilar, why don't you take it away, and thank you all very much for being with us tonight.
Thank you, Dr. Rios, for your welcoming remarks and your wonderful work throughout the many, many years. I'm Pilar Guerrero. I'm from Chicago. I wasn't born in Chicago. I was born in Mexico, but I was raised in Chicago, and I'm the chapter chair, the Chicago chapter chair for NHMA. I'm also on the board for NHMA, and I work at Cook County Emergency Medicine. I've been there for 18 years. I'm interested in anything under health equity, disparities, mentorship, language, anything under health disparities. And I just want to welcome all our panelists, because this is going to be an awesome presentation, and I'm happy that you're able to give up your time and your knowledge to participate and enlighten all of us. Javier, I'll turn it over to you, and then I'll introduce the speakers. I can just briefly going over housekeeping. The presentations will be 10 to 12 minutes approximately, more like 12. Microphones will be muted, unmuted. If you want to ask a question, you can also use the chat icon to write your questions. And the recording is ongoing and will be available next week at www.nhmamd.org. Javier, after Javier's introduction, I will then go ahead and start introducing our panelists.
Thank you, Pilar.
Mhm.
My name is Javier Francisco Sevilla Marti. I am originally from Honduras, and I have been in Indianapolis for over 23 years. And I have been a member of the National Hispanic Medical Association since 2004, and have been enjoying the conferences, and sad not to see everyone in person, but happy that we could at least do it in this fashion over the internet and be able to connect to each other. My efforts here in Indianapolis, with the support of Dr. Rios and the National Hispanic Medical Association, have been access to healthcare and opening opportunities for medical students and residents in healthcare. So that welcome everyone to this beautiful time.
Wonderful. Well, without further ado, I will first say that there is no conflict of interest from my part with any of the presentations. I will introduce our first panelist, but before that, the title is COVID and Latinos, or Latinos and COVID. Before I introduce Dr. Gomez, I want to say happy Mexican Independence Day, because it just couldn't be more appropriate on such a beautiful evening. So Dr. Gomez, Maria Gomez, is Mexican born. She came to the States at a young age and was the first in her family to acquire a medical degree. And not only did she acquire a medical degree, she did emergency medicine residency at one of the toughest residencies in the country, that being Cook County Hospital, or Cook County Health. She also completed a fellowship in tactical medicine and was part of teaching a SWAT team for Northern Illinois, teaching medics. And as of more recently, she's now spreading her time in improving the Latino healthcare and working on disparities with one of our groups here. And oh, I couldn't forget this. She is an American combat veteran. Dr. Gomez, thank you so much for that service. Go ahead and take it away.
All right. Thank you, Dr. Guerrero, and thank you for everything that you do. And thank you, everyone, for being here tonight. And importantly, Feliz Día de Independencia a todos los mexicanos, all right? Celebrate safely, all right? And make sure you wash your hands and socially distance. Very important. All right. So tonight we are going to be discussing Latinos and COVID, right? The role of language and race, especially when creating resources. If you look at this map, you'll see that Latinos, currently, we're the largest ethnic minority in America. We make up about 16.7% of the US population, and we continue to grow and do plan on continuing growing. All right, next slide, please. You'll see that we come from a variety of different backgrounds and cultures. A large portion is Spanish speaking, but we are within ourselves a very diverse entity, right? We use more languages than just Spanish, and we come from different countries and different cultures. All right, next slide. It's predicted that we will be the majority minority in some years. Around 2040, we're going to even out and we'll be the largest ethnicity in the US population. Before we get there, we have a lot of planning and issues to address now in present day. And unfortunately, racial disparities is an issue. And along with racial disparities, right, because this is an umbrella term, right? It has many facets under it. Along with it come healthcare disparities. Next slide. Latinos are disproportionately affected by social determinants of health. This is a fact. There's an overabundance of evidence to support this, all right? I'm not here to argue about this. I'm here to present it as what it is known as a fact. You can collect the data, there's evidence, and whatnot. And sadly, this isn't new information, right? Healthcare disparities amongst our population specifically have existed for quite some time. And COVID has exacerbated it. It's put this already known information into the forefront. I'm going to tell you a few things, and I want you guys to really think about this, all right? Latinos residing in the US are on average 4 times more likely to not have finished high school, twice as likely to live below the poverty line, and 20 times less likely to speak proficient English than non-Hispanic whites. And later on, you're going to hear about COVID, Latinos, deaths, and positive cases. And the numbers are, unfortunately, they're shocking. Next slide, please. Healthcare disparities include a lot of things, right? This is also an umbrella. We're referring to healthcare access. We're referring to the utilization of healthcare, the quality, affordability. These are all factors. And there's a wide number of socioeconomic factors, right, that contribute to these disparities. Interpersonal barriers are also crucial elements. This includes communication and language. Next slide, please. There are studies showing that Spanish-speaking patients and Spanish-speaking people seeking healthcare advice specifically had very different outcomes and certain factors if that advice was provided by another Spanish speaker or same race healthcare provider. Statistically significant differences in recall, questions asked and clarifications, right, and trust. And you're going to see that these studies in trust were actually replicated in the pediatric population. Next slide, please. There's a great study done in Mount Sinai, New York. And this study directly observed the patient to provider encounter. So it was either a Latino Spanish-speaking patient to a Spanish-speaking provider versus a Latino proficient in English, but Spanish was their first language, to an English-speaking only provider, or a Spanish-speaking patient with an English-speaking only provider using a translator. The encounters were directly observed, recorded, and then the patients themselves were interviewed afterwards. And they were asked details about certain details regarding the encounter, including diagnosis, laboratory, treatment, recommendations, social and personal advice. And if you look at the actual data, you'll see that overall in each category, the Spanish patient to the Spanish provider, that resulted in higher recall in every single category. But I want you to take a close look. If you look at social and personal, it was 90% to 33%, right? This social and personal advice is specifically about lifestyle habits, right? Quitting smoking, dietary habits, exercise, all those things that affect cardiovascular health that are actually crucial and unfortunately disproportionately affecting the Latino community, things that we actually want our patients to recall. Next slide, please. In that same study, they looked at questions and clarifications that were made by the patient. All right, so these questions include a kind of a closed loop of communication, right? The patient, if the patient wasn't clear on something, they asked for clarification or they verified what they heard. And what you'll see is 58% asked questions in the bilingual category or made clarifications, whereas 40% did in the Spanish to English speaking category. Now, this could be for a variety of different reasons. It isn't showing causation, but the numbers are very interesting to look at. Next slide. The New England Research Institute completed a study just on trust, asking specific questions and grading out the providers on competence, confidentiality, and honesty. So questions like, do you think your provider is thorough and careful? Do you completely trust the decisions made about your treatment? Do you think that your provider has your best interests, right? And people had higher trust in providers that spoke the same language and were of the same race. Next slide. The study on trust specifically, one titled Language Matters, had been replicated in the pediatric population, showing that Spanish-speaking parents have a much higher rate of mistrust for English-speaking only providers. Important, right? Because we want the whole family to stay healthy and we want the parents to trust us and trust the information that we're giving them. Next slide, please. So how is this relevant? Consider this in the era of COVID, right? Of course, we want our Latino community to recall as much information as possible. We want them to ask questions, get clarifications. And the information has been fluid because as we've been providing the information, We are living through it, right? So things have changed, guidelines have changed, right? So we tell the community how to wear a mask, when to wear a mask, to distance, to wash their hands, right? We want them to stay healthy. We want them to follow the information, but we also need them to trust us, right? This becomes especially important when we want people to participate in the vaccine trials. We want them to trust the process and know that it's safe for them, right? We want that representation in the trials so that we know that it's effective in our community, and we want them to trust the vaccine when it is finally released and available. Next one. So how do we do this? We provide that information in Spanish. We go to the community itself and provide resources and assist in any way we can. So Illinois UNIDOS is one of those groups. It's a coalition. It's a group of community leaders specifically, including Latino elected officials from the Chicago City Council, Cook County Board of Commissioners, Illinois legislature, representation from Congress, together with health experts, doctors, social workers, other representatives in the healthcare field from different areas of healthcare, and importantly, representatives from community-based organizations. Organizations that are already out there have been working with the community and working hard to assist not only in COVID era, but in areas beyond COVID, right? So what we did is got together, developed, implemented a comprehensive bilingual public awareness program, right? This is important because you have to get that information out there in the Latino community in a language they can understand. That language barrier is so important, right? Comprehensive bilingual outreach and education, right? Education is crucial. Knowledge is power. The ability to ask questions and confirm understanding is vital, especially right now during COVID, as the information is fluid and changing and as we're learning more, right? Implementing a comprehensive education campaign targeting small businesses. And the reason this is because we know these small businesses are in our target areas in the Latino community. We know that they've developed relationships. We know that they'll trust that information. Data collection on race and ethnicity, which is just crucial because if you turn a blind eye, you don't take race into account, then the disparities are just going to continue completely untamed. All right. Implementation of universal screening and to ensure that everyone has access to testing and everyone is eligible regardless of citizenship status. Oh my gosh, this one is a personal one to me, right? I came to this country undocumented, with my family undocumented, all right? And we know, and everyone should know, that undocumented workers contribute to this country's economy, to this country's well-being, right? They've been working through this pandemic and don't have the same access to healthcare? No. COVID does not care about immigration status. It does not, right? But we need to care about our essential workers. We need to care about our community. We need to make sure they have PPE. We need to make sure they have that access to healthcare. It's just an absolute must, right? And lastly, representation of Latino leadership in the Illinois and Chicago Health Equity Task Force. This is important because you have to get to representation from the community in these policy-making forums. You have to hold someone accountable. You have to stay on them and say, listen, this is happening. This is what needs to change, okay? So in summary, having this coalition assists in getting vital information out to our community, vital resources, and helping maintain our Latino community healthy as we can make them, hopefully. All right, and I think that is it. Thank you so much.
Couldn't be better.
There you go. Okay. Sorry about that. I had muted myself. Wonderful. Thank you, Dr. Gomez, for such a wonderful presentation to start us off on the importance of language as a barrier and how it leads to health and equity. Next, I believe Dr. Vergara is here, but
I'm right here, and so sorry for being a little tardy. I'm ready to go if I can share my screen.
okay.
Wonderful. Thank you.
So let me just, okay, so can we change the slides then, Ben? Is that okay? Dr.
Dr. Guerrero.
Great. Dr. Pamela Vergara-Rodriguez is triple boarded physician who also works at Cook County Health or Cook County Health Systems. She is boarded in internal medicine, psychiatry, and addiction medicine. Has been working there for over 15 years. Has also been a recipient of several, more like many, social service grants to improve health care outcomes of underserved populations, including Mexican immigrants, the LGBTQ population, and persons living with HIV, as well as persons living with substance use disorder and or mental illness. She's going to talk to us about COVID and the Latino population in Chicago. Dr. Vergara, it's all yours.
Thank you so much for the introduction. And first and foremost, I just want to give a big shout out myself. I'm a primary care provider. I'm an HIV primary care provider, an addiction medicine provider, and a psychiatrist. And I can tell you that firsthand, this pandemic has not only impacted myself and my colleagues, my nurses, medical staff, social services. We are all impacted. And I just want to give a massive thank you to all of you out there who have tuned in now to allow us to share this frontline information with you and to hopefully give you a little hope. That's really what we're here to do. So thank you for spending this time away from your loved ones and giving it to us. And I hope that you get something from tonight. And please know that we're very happy to answer questions and give our personal emails to anyone out there who wants a hand outreach, because I know for me, that has been a huge, huge benefit. So just to start, I want to make the overview. And if you wouldn't mind, Ben, can I share the screen with my updated slides? Is that okay?
Yes.
Great. Okay. I'm going to share my screen right now. Excellent. Here we go. Okay, so my title here, Stopping the COVID-19 Pandemic here in the Latin Community. And I want to give a shout out. I am from Cook County Hospital, and I want to just give a huge thank you to my Ruth and Rusting Core Center staff for always being behind me in any endeavor I do. That's my medical home at the county. Oops, here we go. There we go. So to start with the data. We are living history, there's no question about it. This pandemic has taken us all just by major hit. I want to start with that. And then we're going to talk about the mandate. What is the mandate to us? And give you some of the background about Illinois UNIDOS, which Dr. Gomez mentioned, and what activities we're doing. And I just saw a question in the chat box of what can medical providers do? And I really hope I can give you some ideas. And last but not least, I want to talk about the marathon. Winter is coming, folks. It is around the corner. And we are in for a marathon. So this is the moment to hold on to your horses and to the people around you to make it through. We need each other. So the data, and this is coming from the IDPH website. This is April 30th up until now. August 30th was the last day we accessed this. This is data put together by the Latino Policy Forum, which is a great website. I invite you all to check it out. Lots of resources for our Latino communities. And thank you to them for sharing their slides. We can see here that from April to August, cumulative number of cases increasing, but the key thing here is this. Even though the cases are rising amongst all groups, the line is steeper for the green, the Latinos. That line is starting to, the separation you can see began in May and it continues to separate. Here we are in August and the line continues to be steeper with the number of positive cases. Looking at it from a different point of view, still from IDPH, we can see that when we compare, and this percentages here are as of September the 7th on the IDPH website, which is accessible by anybody. But I want to point out here, we can see 15% versus non-Hispanic, 5% test positivity rate. And that's to say that still of the unknown people who are testing positive, we estimate that 50% of those at least are Latino. And this is based on data, based on last names, and cross-checking information between hospitals and testing sites. Now let's look at it from a different point of view, because however you cut the data, and this is the most important data, cases per 100,000 persons, we can see the Latinos are and also African Americans, are largely more impacted. And this is really the data we need to look at, because this is where we can see a true comparison of the number of cases of Latinos being testing positive versus other groups. Now, here's what we get from the Latino Policy Forum. Okay. When we compare that as of August 30th, the last 14-day case positivity rate, 12.8% for the Latino population versus 4.2% average in all of Illinois. It's 3 times the average rate. What I want to say here is that no matter how we look at the data, our community is suffering. We are 46%, half of all of the new cases in Chicago. 20%, 1 out of every 5 of Illinoisans. How does that translate into deaths? Well, if we're 40% of all of the positive tests, you would think potentially would have more deaths. We have 33% of all of the deaths. When you think about the fact that we are not 40% of all of the people in the population of Chicago, this is Chicago data, but we have 33% of the deaths, 1 out of every 3. This is just absolutely unacceptable. And when you stop to think the people who are Latino are testing positive at a younger age, that means those deaths are also amongst people who are younger. So we are losing heads of households. We are losing folks who had 30, 40 years ahead of them. We can look at it a different way via zip code. Still, we see highly impacted zip codes with high majority Latino population. And looking at it another way, testing and deaths by zip code. When we look at this, 9 out of the 15 top communities are affected are largely Latino. So no matter how we look at the data, we are being largely impacted, and there's no question about it, and we need the resources. And outside of Chicago, the same thing. Our essential workers, seasonal migrant workers, poultry, meat packing industries, all of these folks are testing positive at alarming rates. And what we need is to step up and ask that we get an equal response in resources. And that's what Illinois UNIDOS is about. Now, I want to talk about the medical call to action. There's no question that since the beginning, medical providers, nurses, medical staff, everyone has been stepping up. We've been asked to work more, cover more shifts, do work that maybe we never did, cover the ICU in some cases, asked to cancel our breaks, not go anywhere, make a lot of sacrifices. But you know, that's not the hardest part. The hardest part is the different work we've had to do, outreach people, doing telehealth when we don't have the supports to do it, or even potentially staff that don't have PPE, no social services. Right? These are the things that we need. And we've been asked to do this work and really go at it. And we have. It's been absolutely amazing. But above all, what we really had to do is to address the anxieties and the worries of our patients. We've been forced in a position of feeling powerless, listening to people, listening to their stories, to the people that they've lost. And that puts us in a very high risk for things like depression, anxiety. So we need to figure out a way to hold ourselves up in this world and in the forthcoming world that we have ahead. So I'm going to tell you a little bit about my story and how I got involved in this. I got a call from a colleague who had given my name to the governor's office to come speak at one of the lunchtime events, which never actually happened. But because I was so nervous about it, I, of course, emailed several people in the city of Chicago, and they responded and they said, you should really speak to these folks. Illinois UNIDOS. And I said, who are they? Well, I have to say, they're an extraordinary group of people who kind of took me out of a state of helplessness, of listening to story after story with my patients, trying to figure things out. I was really in the dark. And I have to say that joining this group has brought so much light to the situation by hearing other people able to find solutions that perhaps I couldn't see. And not only that, allowing me also to bring my experience and allowing me to share and give some of what I have to give. Now, who are these folks? Well, Illinois UNIDOS is a group of self-appointed volunteers. These are people who have decided and committed to a group, a weekly working group, a network, a partnership of health providers and organizations, human service organizations, public and private businesses, government representatives from various places all around Chicago and Illinois and suburbs of Chicago as well, to get together and really think through and identify the problems and try to come up with solutions. So what are we doing? And this is actually from one of the first steps in setting up our priorities. First and foremost was changing the message, increasing public awareness with cultural sensitivity, linguistically accessible information. Because without that, there was no way that we were going to be able to help the community understand the real problem. And by doing so, working with community-based organizations and trying to outreach as far as we could. In addition to that, at the top of the list was really correcting the information that we were getting through all of the testing sites and really making it a point to accurately identify who was being affected and to actually get the resources ultimately to be able to address the problem that's at hand. Of course, the thought of universal testing is still there, but expanding testing was the first step. And thankfully, we've been managed to increase that. And I think Chicago and Illinois continues to need to increase accessibility to texting. We've made major strides, but we're still not there. And I can't say enough about the contact tracing. This is a key piece that we're all gonna play and that we've been pushing to make sure that this will be actually successful in Illinois. And of course, we have to demand the financial resources to be able to do this. And there's gonna be more about this, but this is a key component. How do we do this? We increase representation. We need to get to the talking table, and that's the bottom line. There were three main hows of how we did this. First and foremost is changing the media message. It wasn't necessarily about Latinos living in multi-generational households, though that's true. The bottom line is that Latinos are primarily essential workers, at risk and not having the privilege to maintain a shelter-at-home status, even now, nor having the privilege to take sick time, nor having the privilege necessarily to get stimulus monies. All of this was messaging that needed to be changed for the community to feel less blamed and more active, more empowered. In addition to that, we continue to advocate for accurate data, and we all need to work on this, each and every one of us. If you work at a hospital, if you're testing, we need to get the accurate data. Without that, we cannot get future resources. And last but not least, we need to fight our way to the tables. We need to really push all of our government representatives to respond to our needs. To do all of this, I want to say that in the beginning, this was absolutely overwhelming. There was a flood of emails. Every single time there was a new resource, a housing resource, a resource about how to try to get into unemployment, how to address your testing bills, this would come out in just massive emails. And in the beginning, I had trouble managing it, but let me tell you that it was amazing to be able to, during the weekly calls, just message someone and say, I need that resource. And 3 or 4 people immediately emailed, here's the resource, here it is, here's available to you at the touch of your fingers. This is the kind of community that we've built. Now, how did we do this? Well, arduously from April to August with weekly meetings on Saturday mornings. And you may ask, wow, that's 2 hours. Yes, it was highly committed. We broke up into some very important subcommittees. The Health and Policy Committee, which is working very hand in hand to put forward policies that can potentially change our practices. And currently we have our Education Committee that is going strong at the Going Back to School initiative and digital accessibility, of course. During these meetings, we had lots of testimonials from the front lines to really bring home the message of what the community was living. And we had a number of speakers from various offices there to listen to our voice and also to answer some important questions, some very tough questions. And this continues to be the case. On the Health and Policy Committee, of course, it was not only about frontline information, but it's also about making those communications and lending expertise to other organizations that are in the community to partner up. For instance, most recently, we've had partnership on the vaccine trials and trying to get people to come into the vaccine trials and trying to message that it's important for our community to engage in those vaccine trials. And those are the kinds of town hall meetings where definitely the medical providers have played a massive role. In addition to that, just playing a role on task forces and making sure that our voices get heard. This place was really a place to share ideas and to work directly on the ground to come up with policies that we think can really make change. And I'll tell you, we did make change. We did a number of press releases about the increasing number of positive testing amongst Latinos. We also called for greater restrictions when the test positivity rate was not coming down for Latinos. And most recently, we talked about the Latino workers who require higher safety protocols and were not receiving proper requirements for safety in the workplace. We've also done this through mainstream and social media. TV, medical providers, various folks, researchers have gone on TV, gone on radio shows to really talk about the things that need to happen and call for data correction. And I'm so proud to say that WTTW, Hugo Balteras, is now hosting a show on Saturdays at 6 o'clock called Latino Voices. So I invite you all to tune in. Other important outcomes is just being invited to talk at the table, the health equity table, the state data collection table, anti-violence task force, racial equity, food access, it goes on and on. Many of our folks have been actively working on community-wide working groups, county working groups, Illinois statewide working groups. And most recently, working on contact tracing and trying to get promotoras, community healthcare workers that are trusted individuals in our community to get people in, and these people will be absolutely key in the future for us to be able to fight this pandemic. I can go on and on, but I want to point out just some wins that we've had in these recent times, getting additional bicultural, bilingual positions for contact tracing, being able to get stimulus money for mixed income households, being able to get more employment resources, working towards the digital divide. These are all things that are ongoing, on and on and on. And here's where the marathon comes, right? This is a marathon. We have to be a united community. As a medical provider, as all providers, community providers, we have got to really help everyone understand why quarantine and isolation is so important. And if that means separation from your family, so as difficult as it is, we need to give the message that that is a separation for love and protection and safety. We need to address this idea of fatalism that, oh, if I get it, then whatever will be, will be. We need to help people understand they are not powerless, but give them some hope and help them understand that if they get in early, we can prevent the morbidities from the infection. And vaccinate. If there is one thing that we're all going to do, is to take the time for those who don't want to get the flu vaccine to explain to them why getting the flu will decrease their immunity and make it more likely for them to get a comorbid co-infection with coronavirus. And push the vaccine trials. And if you are a medical provider, you are at risk for getting coronavirus, you can enter a COVID vaccine trial and represent Latinos in those trials. So I urge you, each and every one of you, to do that and sell the contact tracing. None of us want to divulge personal information. None of us want to say, oh my God, I had corona, now I have to tell this person and that person. And oh my God, it's as if I had an STD. I am an HIV doctor, so I've had some experience. Telling them that this is a positive thing, keeping people safe. It's about safety. I also want to urge you, if you don't have social services available to you, reach out, find a community-based organization near you. They will be happy to partner with you to help your services and figure out how to work together. If you haven't done that, look around or email us. We can help you find someone. And last but not least, of course, I'm a psychiatrist. I have to talk about trauma, but I want to share an idea with you because we are living a cultural trauma. We've seen people we love die, story after story of how people became ill, story after story about how someone could not access care. We're done trying to survive all the time. We don't want to just survive. We want to thrive. Let's not be just survivors. But to do that, We've got to get beyond this trauma of understanding that coronavirus has not only amplified, but uncovered massive health inequities. We have to just speak clearly that race is a health inequality, not necessarily in an emotional way, in a matter-of-fact way, and move beyond that. So I share an idea with you about post-traumatic growth. What is it? Well, we know what post-traumatic stress disorder is. A traumatic event happens and you develop a series of symptoms that makes you relive that situation. Many of our patients, some of which are immigrants, some of which have dealt with racism, have had these types of traumatic experiences. And I venture to say that coronavirus is a similar experience in which they feel helpless. So the post-traumatic growth part has to do with helping people step back, helping ourselves as medical providers step back and look to see what the potential positives of the situation might be. And perhaps we needed this kick in the butt to get ourselves out there, advocating, saying race is inequality that comes through health outcomes, and we need to do something about it now. This is the experience we can all have. I don't want to speak about self-care because I know right now it's really hard, but I want to share with you a few things that I have done in this last few months. And that is, I get to have Tabasco sauce, and if I go to Taco Bell, I get to have Diablo sauce with whatever I want. All the time, even if I get heartburn. Haha. Yes, I got a COVID puppy. That was a bad idea, turned good idea, turned bad idea. It all depends. Ask me on which day. This is my Che Guevara little puppy dog. And last but not least, because my background is in art, I go to Frida Kahlo. And I get to space cadet with Frida Kahlo and fantasize. And I can fantasize into the future that these hard workings that we're doing now, that hopefully in the future there will be a silver lining, that this pandemic brings us closer to that equality that I know that we're all working towards. So I hope you can all hear me when I say thank you for being here. Thank you for doing the work that you do. And let's thrive. Last of all, I want to say thank you to the Illinois UNIDOS family for inspiring me and pushing me to my point of advocacy that I think I need to live up to and that I have always wanted to. So thank you to them. Thanks so much. Pilar, you're on mute.
There we go. Thank you. Thank you so much. That was absolutely a wonderful, very invigorating, very motivating. You injected us with hope. And yes, go Illinois Unidos, because they are doing wonderful work. I'm going to now introduce our next panelist, Dr. Derek J. Robinson. I know we're a little bit behind time, so I'm going to try to make this short. He is the Vice President and Chief Medical Officer for Blue Cross Blue Shield here in Illinois, and the founding chair for Health Equity Steering Committee. It looks, he's been working for over 2 decades in diversity and inclusion, both for undergrads and graduate students. He sits on the Diversity and Inclusion Advisory Committee for ACGME. He also served as a physician executive for the Illinois Health and Hospital Association and is the former medical officer for Centers for Medicare and Medicaid Services. And he is also emergency medicine boarded. lots of us here. Without further ado, thank you so much for joining us, and take it over, Dr. Robinson.
Well, thank you so much, and Javier, thank you both for your leadership in the Chicago and Indianapolis chapters. Dr. Rios, thank you for your leadership on a national.
Thank you.
It's truly an honor to be on this distinguished panel today. I feel really energized to be here with my fellow physician advocates who are really fighting for improved health for our communities that we know have suffered disproportionately pre-COVID and during COVID. And so congratulate them for the leadership that they've demonstrated, and appreciate everyone being here with us tonight. So not to duplicate some of the very important topics that have been covered thus far tonight, I'm going to talk a little bit about insurance coverage in the Latino community, what we've seen post-ACA into COVID, what have been some of the experience that we've seen around unemployment and individuals becoming uninsured. I'm then going to spend a little bit of time talking about what some of the actions that health insurance companies have taken. And I'm going to talk a bit about our journey around health equity pre-COVID, and then also talk a little bit about some of our COVID responses. So if you go to the next slide, this slide demonstrates a chart. We're familiar with it. Pre-ACA, we know that the Latino population had one of the highest rates of uninsurance in the United States. We've seen those numbers come down. The latest number on this chart is in 2018, but we still note that even if you look at the 2018 uninsured rate amongst Hispanics is at 19%, that's still higher than where the African American uninsurance rate was pre-ACA, for example. So we do see that persistent disparity in insurance rate or uninsurance rate across populations. We move to the next slide. This is just a reminder that, we talked about the significant disparities that we've seen in both COVID infection rate, hospitalization, morbidity, and mortality in the Latino community and the African American community. As COVID has hit, we've also seen, all communities impacted by the shocks to the business community and unemployment, but we also see that based upon this chart from the Department of Labor that was published in the Washington Post, the Latino unemployment rate being significantly high at 18.9%, basically at 19%. So let's go to the next slide here. And the reason this, that unemployment rate is important is because we know that according to Kaiser Family Foundation, about 49% of Americans get their health insurance through their employer. In Illinois, we know that number is about 53%, or about 6.6 million individuals. The Commonwealth Fund did a survey between May and June of this year of individuals to get a sense for unemployment and the health insurance implications of it. So they found that 1 in 5 individuals either lost a job or their family member lost a job, which had an impact on their insurance rate. They were either lost a job or were furloughed. We see that the Latino population was disproportionately impacted within those individuals that lost a job. We also see that there are more individuals who have an income of less than $50,000 that are impacted. The next slide looks at the health insurance experience of individuals who don't have jobs. 53% of people still, if they lost a job or were furloughed, still had some insurance coverage through their employer. Many of us are familiar with the Paycheck Protection Program, or PPP, which was launched in April, which provided loans to small businesses up to $10 million. And those loans actually are forgivable if those businesses spend 60% of those dollars on payroll-related expenses over the 24 months of that program. So you do a quick math, 24 divided by 4 is 6. That's 6 months. 6 months is like October. So one of the things we get concerned about is how might these numbers change as we move into October and beyond, and what does that impact in terms of loss of coverage might look like for diverse communities. So we could see more heartache around the corner. The next slide looks at those individuals who lost a job but didn't have employer insurance coverage to start. About 1/3 of those individuals had coverage through a spouse. 1/3 had coverage through Medicare, Medicaid, or the ACA marketplace. And 1/3 of those individuals remain uninsured today. So insurance coverage is a significant issue. And as we see these shocks to our businesses and employment system, the implications become even greater. Next slide. Now we know that the ACA has been controversial since it was passed. It's afforded many benefits to individuals that are both insured as well as individuals who were previously uninsured, and has been a subject of a lot of litigation and political rhetoric as well. But this survey does reflect across racial and ethnic groups, as well as from a bipartisan perspective, that there's support for individuals having comparable access to employer insurance either subsidized by the government or in a government plan. And so there's certainly folks really want to be able to maintain coverage independent of their employment. So let's go to the next slide here. I want to talk a little bit about our journey to health equity as a health insurance plan. Both of us are aware that all of us are aware there's been a significant push around health equity, both as COVID-19 has exposed in the spotlight of the pandemic the disparities that pre-existed impacting the Latino community and others. And then also in the wake of the George Floyd killing and increased focus on systemic injustice, there's been a lot of push here. But I think it's important to talk about some of the work that we've done that actually preceded that, because these phenomenon that we're spending a lot of time talking about and struggling with are not new. Just to give you some context, Blue Cross and Blue Shield of Illinois is a very large health plan. We spend about $25 billion in healthcare services each year, with about 8 million members that are located have their insurance under our Illinois plan. About 1/3 of those individuals are in some sort of fee for value or value-based care program. We also have a very large HMO in the state of Illinois at about 660,000 members in it, with 80 IPAs that support that. If we go to the next slide, I'm going to talk a little bit about some of the things that we've been doing going back several years. You know, some years ago, we did have a cultural competency program that was launched with our providers. We brought that back recently because we recognize that it's important to educate and sensitize our broader provider community to the cultural norms and needs of our diverse populations, and also to strengthen our understanding of implicit bias, which is something that's natural that we all have, but how it plays out in a clinical setting. And so that's something that we have brought to bear in our HMO program, for example. We actually incentivized the completion of both cultural competency and implicit bias training for providers across our 80 IPAs, which means we made money available as an incentive. We also actually paid for the programs. And so that program ran across 2019. We ran this forward in 2020 with our ACO provider partners as well. If you go to the next slide, this also just reminds you that, we go to the next slide. Going back to 2017, we actually began having conversations with our ACOs in the state of Illinois. And with that time, we established a voluntary health equity program, which encouraged education in some of the areas that I've talked about. We also encouraged the collection of race, ethnicity, and language data, and to begin to go down that path of stratifying that data to identify and reduce and eliminate health disparities. You know, I recall having conversations with some of the ACO leaders in the summer of 2017, because by that time, none of the ACOs had actually signed up for that voluntary program. One of the things I told them was, in the future, these are not going to be voluntary, but it's going to be kind of a core part of the program. And I remember some saying, you know, well, we don't really see race in our practice, or others said, well, we never really thought about it as being an issue to address. Fast forward, in 2020, we've moved from it being a voluntary program to a program that has financial incentives that are tied to it. We have a number of ACOs that are participating in it. And it has a 3-year kind of glide path around both the collection of data, race, ethnicity, and language, stratifying clinical data, and then moving towards the reduction of disparities in several focused clinical areas. If you go to the next slide, I'm going to run through some content pretty quickly because we're short on time. We have also worked with the American Hospital Association to help advance their Health Equity Pledge program, which when hospitals participate in that, they have governance leadership that's signing on to many of the principles around health equity. We put forth $1 million in incentives to try to get more hospitals in the state of Illinois to either sign on to that pledge or move up to different tiers within it. These are just some of the hospitals that were selected. We started working with the AHA on this in 2018, but actually got it launched in 2020. Next slide also shows that we've been doing some strong work with the American Heart Association, our other AHA partner. They have a new program called the Social Impact Fund, which they rolled out last year, where we've, through this investment, have been investing in small businesses on the west side and the south side of Chicago that serve diverse communities, helping meet both their nutritional and some of the economic needs in those communities to help improve heart health. And these are some of the examples of some small businesses that have benefited from that program, and great stories that you can learn more about on our website and our newsroom. Next slide. And then it's here also reminds you that, you know, our work has gone beyond just the clinical space. We're also investing in jobs. And so we've opened a major work center down in on the south side of Chicago. We have another one that will major facility that we've signed an agreement with in the Pilsen community. Next slide. So Blue Door Neighborhood Center, this is something that's new for us. We rolled the Blue Door Neighborhood Center out just over a year ago in the Pullman community. The next slide, if you go to that, it will show you that these centers provide a number of different services, from fitness to health education, care coordination, meeting spaces for local nonprofits. This is not for Blue Cross Blue Shield members exclusively. This is for the community. There's no time more important than now to build trust in diverse communities. And so we want to ensure that these communities know that we're here to stay. We're here to ensure that they're able to realize their best health potential. And when you think about a lot of what we've discussed around COVID and COVID education and flu vaccination and subsequent COVID vaccination, we've got to be embedded in the community, trusted partners. This is part of our effort to do that. Next slide. This gives you some of the locations where we currently have Blue Door Neighborhood Centers and opening additional ones up. We're looking at the data very granularly to understand where are the communities where we feel like we can have the greatest opportunity and greatest benefit. Next slide. And we're going to go to the next slide because I want to be sure we are mindful of our time. When it comes to looking at COVID, we've been very engaged. We've supported the Illinois COVID Response Fund at $1 million, the mayor's Chicago Community COVID Response at $500,000. We also launched over $1.5 million in community grants, $20,000 grants to community organizations as part of our Rapid Response Fund. We, you know, as an emergency medicine physician, I know providers are struggling with access to PPE. We pushed out 150,000 respirator masks in the early part of the pandemic to support that. And then we also gathered our teams up, 50 volunteers, 12 different communities across the city of Chicago, passing out masks in the community, encouraging folks to protect others by wearing a mask. And the next slide. And this is an aggregation of the value of many of the things that we've done in terms of member cost sharing, the expansion of telehealth, community investments, grace period extensions, things that we've done in partnership with both employers and as well as with our members during the COVID-19 experience that we've had during the pandemic here to help ease the financial burden, and that's valued at over $300 million. So I think I got through my slides in the time. The point here is that our efforts have not started just during COVID-19 around health equity, but actually preceded that, and we look forward to continuing to work with the NHMA, MA, and others as we move forward to improving health for all communities. So thank you all very much.
Thank you so much, Dr. Moran. That was
Thank you, Dr. Moran.
Also very, very enlightening. Just for the audience, we are over and we're aware that we're over, but there are some really good questions in the chat that came through, and whoever wants to stick around, we'll just keep going. I'll start with the few, we have quite a few for Dr. Moran, and then we'll go up from there. What has been done in the last 6 months to gain the community trust for the vaccine? Well, no, I'm sorry. That's going to be more for Dr. Vergara and maybe Dr. Gomez. What has been done in the last 6 months to gain the community trust for vaccine under this administration? Does anyone know?
I actually think that might be a question for Dr. Moran, because one of the things that we've been advocating for, and Dr. Gomez could speak to this, is a plan, not just from the state, but also from the city, about how we can push forward both flu vaccination and hopefully push forward the COVID-19 vaccination. So we've been asking a lot of questions about that. I think, Dr. Moran, if you have information about this, we're happy to hear it, because we know that this is a key point for us.
Well, I would say, you know, are you talking specifically about this administration, or just what can we do to gain community trust for the vaccination going forward? what I can say to that piece is just that we have been in conversation with the CDC because they are very motivated during this emergency use authorization period to ensure that people understand what the vaccines are about, how they will be distributed, how they will be administered, a clear message about safety and a clear message about efficacy if we get to that point. And in fact, they've engaged us to make sure that we as a vaccine developer are thinking that way. And we certainly have been. And so we are just in the beginning stages, I would say, of Pfizer, of partnering with the CDC and others. We have developed a lot of educational materials, which we can't roll out yet because we don't know that we have a safe and efficacious vaccine. So our medical team has continuously been talking with physicians and other immunizers about not just COVID-19 vaccine, in fact, just the opposite, just immunization in general, and the sad state of affairs of immunization rates, particularly in children, but also in adults, going down tremendously. And so we've been doing a lot of work in terms of generally trying to boost, no pun intended, vaccine confidence across the board in terms of what effect the pandemic itself has had on people not seeking health care and therefore not getting their immunizations. So we'd be very happy to partner with you all and be thought partners to think about how best to approach this and do it in a better and more robust way.
I think along those lines, there was another question. Couldn't high participation rate of Latinos in the COVID clinical trials increase Latino consumer confidence if the vaccine becomes available, or when the vaccine becomes available?
Or if I like one, but I still have to say if. I still have to say if. I think that's an incredibly powerful point. I think that if we're doing our best to recruit underrepresented minorities and those impacted disproportionately by this terrible disease. We have a website where you can see it's updated weekly, as I understand it, in terms of the percent of minorities that are recruited to the trial. As of yesterday, we were at about 8% for African Americans, 11% of our participants are Hispanic, about 0.6% are Native American or Alaskan Natives. That's in the United States, and about 5% are Asian. Globally, the numbers are similar, though globally, 7% African American, 27% Hispanic. So, and that's because our trial, I should have mentioned, is a global trial. It's not just in the United States, and it's in a number of countries. And so that was an effort to really try to engage underrepresented populations.
Mm-hmm. Yeah, thank you. Is there any reason why only 39 of the 50 states are being enrolled in the clinical trials?
Oh, that's a great question. I'll tell you, I mean, I'll tell you what I think the answer is. We wanted to do clinical trials in areas where there was a fair amount of disease, right? There has to be disease to be able to show a difference. And so I'm guessing that that's a large part of how the sites were chosen, and there are likely not, if you're a site that doesn't have disease, it wouldn't make the best sense to have a clinical trial there, if that makes sense.
Sure, yeah.
There is another question directed to Dr. Moran. Could a high participation rate of Latinos in the COVID clinical trial increase Latino consumer confidence in the vaccine if it becomes available?
I think we just did that.
I think we did that one.
Yeah, we just did that one right before that. There's another one. How can a bilingual provider help our non-bilingual physicians provide care for our Latino population?
I'm going to let one of my other panelists answer that, because I'm interested in that, because I was in a predominantly Latino, I serve the Latino community, and I am not a competent Spanish speaker, so I want to hear the answer. I've been on the receiving end of the answer, perhaps, but I'd love to hear from you all.
I'll speak to that question, and then maybe Dr. Gomez can speak. I think there's, with every culture, every person that we engage, there's a cultural background, and it's not just their culture or their language, it's their community, it's their personal experience with medical care. That's a big one. Oftentimes, our Latino population has had varied, I would say, interactions with healthcare. I think the biggest thing that drives home right now, though, for our population is the concern for bills, the concern that engaging in healthcare will land them into medical financial crisis. Concern that if they go to the hospital, they might get COVID if they become ill. So I think one thing that we can learn from our Latino population is really trying to figure out with each person that we see, who is this person? What is their history with engaging in medical care? And how is this person most likely to receive information? And also, how is this person most likely to act upon it, right? And that may not be necessarily a Latino or non-Latino thing. That might be more of a community thing. I think when Dr. Moran was showing the vaccine trust scale, I think that to me is a very useful approach of how to approach our populations of all kinds, Hispanic, non-Hispanic. What is their trust in me? And what does the system have to provide to them in order for them to have trust in me? And sometimes that may not have to do with you, the medical provider. As the medical provider, you might be working alone in a silo, but you are likely working with a number of other folks, registration clerks, nursing staff. And so the question becomes, for the population that you're serving, having an understanding of what those particular, and I think if anything, what I have learned, and I work in a very special place in which primary care actually has been adjusted around the bilingual population, which is really monolingual, where all the nursing staff and social service providers actually speak Spanish and are often of Hispanic background themselves. Some of them not, but most of them, yes. And this in and of itself lends itself tremendously to being a trustworthy, a trust giving, giving a sense of a home, of somewhere where they feel they belong. And so what I can say to this question of what can we learn from treating our Latino patients and bring that back to our non-Latino patients, it's really looking and trying to understand that person in the context of how they perceive their medical care. Dr. Moran, if you have anything that you feel you've learned from that trust scale, I think could be, or Derek, also Dr. Robinson.
I think you've covered it nicely. Derek, please.
Yeah, I think us as healthcare providers, joining like chapters or Illinois UNIDOS can serve as role models too, because the patients do trust us. And our those none that are not Hispanic, the physicians that are not Hispanic can learn from that as well. So not only our patients, but so can the non-Spanish speaking providers, because they play an important role, especially in big urban cities like Chicago. Let's see if there's anything else here. There was one for Dr. Gomez. Oh, there was another one for Dr. Moran. mRNA. Are the majority of vaccine trials mRNA, like the Pfizer one, focus on the spike protein? How many targets are identified at this time in terms of inducing immunity?
Messenger RNA is just one platform, as I said, and there are many candidates. The 6 platforms, actually more than the 6 platforms that I mentioned. Those are the 6 main ones, but there's a smattering of all sorts. There are a number of DNA candidates, as well as the tried and true, the viral vectors, the viral parts of the virus being used. So no, it's messenger RNA is not the core of the market, though. I would say that there's some of the earlier candidates. That's why you're thinking about it, and here, because that's what the news is talking about.
Okay. There's a question for Dr. Gomez. In this social network era filled with fake information about the pandemic, the Latino community has sometimes low access to healthcare insurance, but good access to the internet. Do you think they will take the alternative medicine approach if infected with COVID? If this may have a negative or a positive impact on their health? And we know the Hispanics do practice a lot of times alternative.
Right. That is a great question, and I'm glad they're bringing up the issue of misinformation, because unfortunately, especially with COVID, there has been an overabundance, especially on social media. I can tell you, my mother's almost 70 and doesn't know how to put her phone on speakerphone, because she doesn't miss a beat on Facebook. She knows el face. She's like, oh, you'll be in el face, you'll be in el face, right? So she'll ask me, I heard that if I take zinc with garlic, that's going to stop this, and is the mask very necessary? So it depends on, obviously, the data, the actual evidence for what's termed alternative medicine, right? So if there's data out there, of course we'll support it. Do I think the Latino community will veer towards it? Yes, I think traditionally we have, and I think it depends on what that advice is, right? If it's coined as alternative medicine, but it's saying, hey, wash your hands and stay healthy, eat healthy, whatnot, then obviously there's data to support that, and we will support it also, no matter what the coin term is for it. If there's evidence for it and we know it's good for the patient and the outcome is going to be positive, then yes, we will likely endorse it. And it's not likely it won't be termed alternative, right? Because it's alternative for a reason. But unfortunately, if somebody catches something on el face, as my mother calls it, and says, hey, maybe I should try this, and maybe you shouldn't, maybe that plant is poisonous, So it's the duty is on us to do our due diligence and inform our patients as much as possible. And obviously in a non-judgmental way, right? Because we come from these backgrounds, we know the kind of information that is abundant, and we know, that it can be popular in certain communities, and we know that, hey, okay, we might have to do a lot of information exchange. Ultimately, it's putting the patient's health in priority and informing them and making sure they walk out, with a good idea of what's healthy and what's not healthy.
Sure. Thank you. There's a comment and a question from someone in New York. We're a Spanish language senior social center in New York, and we have 100% yearly senior immunization completions because we work with the managed care providers. This should be a direct collaboration with the physician. This should be in direct collaboration with the physicians. A healthcare and social service combination approach works very well. How can we create more of these projects? There is no collaboration hub for our community, our Latinx community. I don't know if Dr. Robinson wants to take a shot at any project that may resemble that, or anyone.
This feels like a collaboration hub right here. Figure out how to innovate and address some of these opportunities. So I would welcome the opportunity to learn more about that program, as I think many of the other physicians on here would as well, to see what opportunities we might be able to seize. We don't always have to invent the wheel. We can learn from some practices that have been successful.
Yeah, and with some of the initiatives you have out in the community, it's just kind of like a ideal partnership. Anyone from Illinois UNIDOS want to take a stab at that, or?
I just want to make a quick plug. For instance, we have one of our FQHCs is doing a town hall meeting and regularly does, periodically COVID-19 focused town hall meetings where they invite various medical providers to talk about lots of things. One of the one that is coming, I believe, at Esperanza will be one that's related to the vaccine trials, and they've invited an infectious disease doctor from Rush Medical Center to talk about this open town hall meeting, and all of the patients and people in the community are invited to this. It's easily accessible. So I think one of the key things here is having some type of ongoing feed of social media information, whether it's Twitter, whether it's Facebook, and it's a challenge to keep saying, this is available for your information, and this is available for your information, and a continual, and it's unfortunate because it's a bombardment of information, but at the same time, it's really the only way that at this point we can do it. I mean, we could go door to door with community outreach workers, or also, for instance, as Dr. Robinson was saying, you know, using our insurance providers, perhaps with care managers, to outreach patients that are already in their pool so that they continue to, you know, hey, we're offering this webinar, we're offering this call-in informational, we're offering this, but it's just going to have to be continual until we get there.
Yeah, we have our work cut out for us, that's for sure. Well, thank you. I want to kind of wrap this up since it is 7:35. So we've taken a lot of your time. One last slide here, encouraging everyone on the call. I know half of them already left, but there's still 43 people there. To join the chapter, get involved at a local level, at a national level, at a regional level, with Illinois UNIDOS, with NHMA chapters, with NHMA locally. Someone, I'm sure, is going to start an Indiana UNIDOS pretty soon after this conference. Our emails are on this last slide. They're pretty hard to read, but you can always get our emails from the NHMA website. I want to once again give my greatest gratitude to all our panelists and to all the NHMA staff, and to Dr. Rios for pushing this through. Javier?
Thank you all for your participation, and especially to Dr. Rios for always being there, not just for these meetings, but to support us at every time. And we really appreciate your leadership, and thank you to all of the panelists tonight for your expertise and willingness to inform us and share with our community. In Indianapolis, we don't have a United Indiana yet, but we have been doing pretty much the same without the name.
Wonderful. All right, everyone be safe and keep the work going.
Yeah,
Thank you all.
You too. Take care.
Thank you.
Bye-bye.
Bye.
Thank you.